So once again, we're here with another edition of the Osteopathic Lyceum podcast. What I want to talk about this time is to essentially build on my claims previously that osteopathy is essentially built on philosophy. So it's primarily built on thinking without necessarily direct relationship to evidence, right? So there is a way to think step by step that does not necessarily include observable evidence, and that's essentially what has built osteopathy, or maybe more accurately, the central building block and central preference of osteopathy. Okay, so what I'm going to do is go through a few things here so that you can take them in and see what evidence bolsters my claim a little bit more. Now, because I have a particular interest in the philosophy of science and the terms ontology, epistemology, and axiology, which I've already discussed, and I discussed in relation to osteopathic philosophy, or really philosophy, and why osteopathy is more philosophy than anything else. I also have a particular interest in the differentiation between the term hypothesis and the term theory. So what I'm going to attempt to do is provide you with insight as to why I will make the claim that osteopathy is primarily devoid of theory, and it would be more accurately termed having the presence of, or it would be more accurate to say that osteopathy has the presence of a lot of hypotheses that are maintained subsequent to their not being proven or not being supported, right? So that's kind of a mumbo-jumbo way to say there's a lot of pontificating going on, and when you test it, the claim or the prediction of the hypothesis and your pontification does not match with observed reality, but it stays anyways. So what I'm going to do is going to share my screen. So for those of you listening, you won't necessarily see this. And this is the one I want to share to start. So first, and that is not the screen I want to share. One moment. There we go. That's the one I want to share. Okay. So I'm going to resize the video here. Please excuse me for the delay in getting this ready. Okay, so first we want to define what a hypothesis is. So a scientific hypothesis. So first of all, we want to make sure that we're in the right realm. So I'm making claims with respect to science, right, or what would fall under the word science. So scientific hypothesis, and this is from the Encyclopedia Britannica, and this is the definition provided, and I utilize it because it seems to be quite in line with what I've already learned in previous settings. So a scientific hypothesis, an idea that proposes a tentative explanation about a phenomena or a narrow set of phenomena observed in the natural world. The two primary features of a scientific hypothesis are falsifiability and testability, which are reflected in an if-then statement, summarizing the idea and in the ability to be supported or refuted through observation and experimentation. The notion of the scientific hypothesis as both falsifiable and testable was advanced in the mid-20th century by Austrian-born British philosopher Karl Popper. So the really key point of a hypothesis, or really key central feature of a hypothesis, there's three. First of all, it's a prediction based on observation. So you've had an observation, you've seen something, you've seen a phenomena, whether broad or narrow, you've seen something, you've observed something. Then based on that, you make a prediction about how it's going to function. When you make the prediction about how that's going to function, it should be formulated in a way where you can test it, right? And that test should actually be able to break your prediction. So if I predict that there's an outcome, my test should allow for me to detect that that outcome did or did not happen. That's the falsifiability. So I should be able to break my prediction in the way that I tested. There may be a better way to describe that, but it gets a little funky sometimes. So what I want to do now is bring this down here. Nope, that's not what I want to do. Darn thing. Now we want to move over to the term theory, right? So my claim is that osteopathy has a lot of hypotheses, right? So there are observations of phenomenon and predictions made about how they work. Now, the thing that has been a problem within the profession of osteopathy that I would claim is that the predictions, when tested and when falsified, are not accepted. They are still the hypothesis is used in place of theory. So theory, and this is again from Britannica, scientific theory is a systematical ideational structure of broad scope conceived by the human imagination that encompasses a family of empirical experiential laws regarding regularities existing in objects and events, both observed and posited. A scientific theory is a structure suggested by these laws and is devised to explain them in a scientifically rational manner. So before I go any further with this, I just want to be very clear on how this definition is written. This definition is written with the philosophical notion that there is argument between a constructivist and a positivist. So a constructivist is going to say, well, a theory is simply a structure of the human mind. A human made it up, so the theory is just in the human mind. The positivist would say, yes, you are likely correct. However, it's pointing at something that's underlying, consistent, and observable, right? So the systematical ideational structure of broad scope conceived by the human imagination, right? That's where the constructivist shows up. The positivist would likely agree with that superficially, but go one step further and say it's pointing at a consistent, observable, stable, underlying phenomenon, right? This is further on in the definition to read it. In attempting to explain objects and events, the scientist employs 1, careful observation or experiments, 2, reports of regularities, and 3, systematic explanatory schemes, which in brackets says theories. The statements of regularities, if accurate, may be taken as empirical laws expressing continuing relationships among the objects or characteristic observed. Thus, when empirical laws are able to satisfy curiosity by uncovering an orderliness in the behavior of objects or events, the scientist may advance a systematic scheme or scientific theory to provide an accepted explanation of why these laws obtain. That's written a little funny. I don't know why it's written that way. It's a spelling mistake or something else, but that's a little funky at the end, where it says explanation of why these laws obtain. It may want to say are obtained or observed. I'm not sure. But basically what you're seeing is that you go from the observation, right? And then the reports of the regularities. The reports of the regularities may precede hypothesis because you have to observe the pattern. And once you've observed the pattern, you make your prediction. The systematic explanatory schemes comes after the consistent observation over time or over repeated bouts. So when you make your hypothesis, it's a set of predictions as to how things should behave under particular circumstances. You then go out and generate those circumstances and you identify whether or not the thing behaves the way under the circumstances that you predicted. If it didn't, then you have to accept the null hypothesis. So basically your hypothesis is incorrect, right? If it does observably follow your prediction the first time, you increase your confidence that your prediction is correct. So you get closer to being willing to make the claim that you have an explanation with your hypothesis for how nature behaves or how something behaves. When you test it the second time, if your prediction again lines up with the observed reality in the testing circumstance, then your confidence goes up again, and your confidence goes up again with the third time, your confidence goes up again with the fourth time. So the more times that your prediction remains stable in that under the circumstances you are observing, your prediction accurately describes what does occur. There's no difference between what your prediction says and what actually happens. Then you increase your confidence to the point where every time you try to break your prediction, you don't break it. You can then say that your prediction explains stable, observable, consistent reality well enough that it can be called a theory. So it advances from hypothesis to theory with repeated testing over and over and over, right? So a hypothesis is your initial prediction. A theory is a hypothesis that has not been broken over multiple bouts of testing, right? Now, what we can do is look here for something to maybe echo what I've suggested. It's from the Merriam-Webster dictionary. It's hypothesis versus theory. Really quick blurb here. A hypothesis is an assumption made before any research has been done. It is formed so that it can be tested to see if it might be true. A theory is a principle formed to explain things already shown in data. That's an interesting one because that actually leads to a lot, or lends credence to a lot of constructivist methods. So constructivist methods will collect data and then explain it, right? They'll make an explanatory framework. So you observe the data that you've collected, often through qualitative methodology. So asking people questions, interview data, looking at written material, things like that. And then you'll make a framework to explain it after you've observed it. So it's like the data is already there, and then you explain it. Whereas in the positivist sense, you make an observation. From that observation, you make a prediction. From that prediction, you generate an experiment or a methodology that could falsify your prediction. If it doesn't falsify your prediction, you gain confidence in it. If it does falsify your prediction, your hypothesis is null. It doesn't predict appropriately, right? So again, we're getting some concept that the things that I'm pointing to, or the claim that I'm making, that osteopathy contains hypotheses that, at least when they've been tested, have not necessarily been supported, but they maintain those hypotheses and will use the term theory from time to time, not necessarily explicitly, but that's the general experience that somebody's going to have. Now, what I'm going to do is I'm going to move over to another paper here. And there we go. I can get to it that way. Good. I can restore this, move this back. So the paper that I'm going to point to is by a gentleman named Torsten Liam. It's called AT Still's Osteopathic Lesion Theory and Evidence-Based Model Supporting the Emerged Concept of Somatic Dysfunction. And this is a paper that I think acts as a decent exemplar of the claim that I'm making. So there's hypotheses, they get tested, they're not necessarily accepted, so they're sort of rejected. You iterate, you keep going through, and osteopathy still ends up in this position where we have this consistent observation that hands-on work has a positive outcome for the patient in some way, but our explanations, or really our predictions, are not accurate to what's actually occurring, right? So we're making these predictions that it's because there's this mechanical dysfunction and that's impeding fluids. Well, sometimes it is, sometimes it isn't. So you have to kind of reject that, or you have to move away from that. Then you say it's because of the facilitated cord segment. So you find a way to test that. And it's like, okay, well, maybe yes, maybe no, but then the methodology proves to not necessarily be what you would want. So you have to move away from that. So you have this consistent, stable observation that hands-on work, the way that osteopathic practitioners tend to do it broadly, has a positive outcome for the patient, but the predictions, the hypotheses, are not supported, right? So osteopathy has a lot of hypotheses that will predict good behavior consistently because we can see it. We get generally positive outcomes, or a range of generally positive outcomes with patients, but our explanations just are not supportable, right? So we'll just go through this in kind of a cursory way. Liam is pointing to Dr. Still and the manner in which he conceptualized things. There's a small piece here that sums it up nicely. Where is it? So the central belief of Dr. Still, right? So this is a claim from what Liam has cited, and he's essentially saying that Still believe that health is based on structural integrity and develops when the flow of body fluids is unhindered. Okay, so Still is working from the outside. He doesn't have the ability to pay attention to internal machinations of particular functions. So he posits that when he does this mechanical work, this hands-on work, and gets the positive outcomes for the patients, that these must be the things going on. He was pre-informed by things that he had read, or he had experienced, or he had observed, and he comes to this place where it's the flow of fluid. So mechanical disruption or mechanical dysfunction, which he termed the lesion, is hindering the flow of fluids. Which fluids? Well, whichever ones he would use the term, whichever terms he would use. You observe that over time. So now when you're able to observe fluids, you have to reject that because things such as arterial blood flow are very good at getting past obstructions and maintaining flow and maintaining target tissue flow, right? So over time, you have to reject that. So the observation doesn't support it, but the stable phenomenon remains. Hands-on work does something good for the patient. right? You go a little further, you get into Guy Dudley Hewlett, G.D. Hewlett, maybe that's how you'll see it, was the first to document the concept of an osteopathic lesion as any structural perversion which by pressure produces or maintains functional disorder, right? So you're seeing the concept expand, you're seeing the hypothesis expand there, right? You get spinal lesion there. George Malcolm McColl criticized Hewlett's definition for the inclusion of bone diseases, tumors, and major injuries, which he claimed would not be amenable to osteopathic manipulation, right? So a tumor is probably not going to change when you mobilize structure. He, in contrast, defined, so I'll go back into the written material. He, in contrast, and this is McColl, defined the osteopathic lesion as any restriction of spinal movement that could be resolved by an osteopathic intervention, right? So you see this broad thing. It's like they're working from the outside. What they notice consistently is when I find this alteration from the outside of the body that seems to be a change in motion of the vertebral column, and I change that, health shows up. The patient has a consistently stable range of positive outcomes. Not perfect, but better, right? So the observation is maintained, right? We go a little farther. We'll just go into the environmental lesion. This is John Martin Littlejohn. John Martin Littlejohn suggested that purely mechanical lesions therefore may not occur, as they are, for example, coupled with mental and psychological states, health, function, and structure. In this regard, he used the term environmental lesion. So Littlejohn was noting that at the same time as he found the mechanical dysfunction, other things might have been going on. So he saw them happening at the same time. So such that if there was a problem with health, Littlejohn was noting that the spinal lesion would be there, or the mechanical dysfunction would be there, but other things would be there too, such that if the other things weren't there and you saw mechanical dysfunction, well, they obviously wouldn't relate. Again, in his point of observation, it's like you have the mechanical dysfunction and no other dysfunction. Well, then you can have the presence of mechanical dysfunction with the lack of a health problem, right? So he was able to identify the difference there. You get Fryatt, and yeah, we'll just kind of touch on Fryatt here. Fryatt and Becker considered the total structural lesion as the primary mechanical lesion in addition to all consequential mechanical compensations. Fryatt chose the term total lesion no longer referred to only mechanical factors, but any factors that predispose patients to disease. These factors include, for example, environmental factors, infectious agents, nutritional agents, emotional factors that can potentially affect health. So what you're seeing is, again, the stable observation that mechanical dysfunction followed by, or the identification of mechanical dysfunction followed by hands-on work from an osteopathic practitioner would generate a stable range of generally positive outcomes, but other factors were noted, right? So they were doing this longer. They noted that you could have a mechanical dysfunction without ill health, but if you had a mechanical dysfunction with ill health, then they related, at least in that they happened in the same person and were observed at the same time, right? Then you get a bunch of further development of that attempt to explain from the environment of observation, which is primarily external to the patient, and making guesses as to what's happening inside. But their iterative observations were going in a generally positive direction. But then what you get is experimentation such as John Stedman Denslow and Irvin Core. Essentially, what they were doing was they were taking EMG needles, or needles that would record EMG. They were putting them in the backs of healthy young college students. So they were at Kirksville, so these were osteopathic students. They were putting those probes in there more or less and making electrical readings, or EMG readings. What they would do is they were looking for the threshold at which you got excitation, or which you got a clear signal. And they noted that in the areas of dysfunction, or the identified dysfunction, that you would have these differences in readings, right? So what they found was a relationship between less stimulus to generate an EMG spike in an area that a dysfunction was identified. So they then assumed that because they had that thing that was related in time, right? So easier to excite the EMG activity in the area of dysfunction, that those must go together, right? Not necessarily unreasonable. They do go together in the observation and in the framework. They weren't necessarily controlling for the variation in individuals, but they would have done that statistically by saying, although the pressure may be different individual to individual, we see this as consistent. They may not have been controlling for other factors, but again, seems reasonable enough. They then go on and look at things like sweating in the area, because sweating is assumed superficially to be driven only by sympathetic nervous system activity, and maybe it is, but there may be other things such as temperature, so the sympathetic activity isn't necessarily generated by one factor. They could have been nervous because of the experimental setting. They could have had bad experiences with needles before. They could have had all kinds of things that would have predisposed them to being nervous and in a heightened sympathetic state. And you try to control for that in the experiment, but they don't necessarily go together. So just because you have a noted dysfunction in the vertebral column, an increase in EMG activity at a lower stimulus or a lower threshold stimulus and associated sweating, that doesn't necessarily mean that they all go together in a mechanistic way. They're observed in similar times, but they may not be mechanistically connected. So then that builds, right? So you go through to the point where now maybe one of the mechanisms that is favored is something like a neurofasciogenic model. So there's nerves and fascia, and the relationship between those is what's generating the dysfunction that is amenable to mechanical treatment or to hands-on treatment. So they're plugging away at ways to explain why osteopathic treatment works in an iterative fashion. The thing that is stable is the observation, as I've noted, the observation that hands-on work. So first of all, the identification of a health issue, a mechanical dysfunction existing at the same time, osteopathic hands-on work, and a generally positive range of outcomes for the patient is the stable observation. But then you have these people making these inferences, making these guesses as to what's going on. And time again, they're not supported when tested. So the null hypothesis must be accepted for all of these. And this is a fundamental flaw in how you're testing. So you have your observation. Well, it's not necessarily a fundamental flaw. It's that they haven't come across the right thing. So one of the things that you might want to do that would line up better with the generally accepted scientific method is you have your first observation, health issue, mechanical dysfunction related, right? So they happen at the same time. Osteopathic hands-on work producing a generally positive range of patient outcomes. First of all, you want to figure out what those outcomes are. Is it only an improvement in movement? Or how often is it an improvement in movement? Is it both an improvement in movement and an improvement in patient report? Is it both an improvement in movement and plus patient report plus some other biomarkers? You want to start testing which biomarkers actually change, or do they change in variable ways depending on the person, right? So does one person respond with a particular biomarker in one way versus another? So you've got this huge array of questions that hasn't been done fundamentally. So we're going to explanation as a profession before we're making more fundamental observations. We've made the base fundamental observation that these positive things happen when osteopathic treatment is applied, but we haven't made further observation of what actually happens. We're trying to explain it without figuring out what the general suite of outcomes is. So if we did that, we might be able to come to a better prediction, or we might be able to come to a better prediction because we had greater observation of the pattern. So we're likely under observing the general pattern, the general pattern of outcomes, both outside of and within the patient, right? So I would say that more observation is needed to get to something explanatory. Now I'm going to provide a little bit of insight here in a way that shows how osteopathy has done this before, No, come on. This thing isn't working the way that I want. So what I'm actually going to do is I'm going to stop the share for a moment. I'll come back to it. And so that I can get to what I want. Actually, I'll do it this way. Haha. Do that. So what I'm going to do is essentially share some insight into how Lawrence Jones, so strain counter strain, how Lawrence Jones came to his observation. So this becomes a really good exemplar of my claim that the general observation within osteopathy has been stable, the general phenomena has been stable, and then you try to explain it, or you try to kind of get to it. So this is from an osteopathic approach to diagnosis and treatment, and this is, I believe, chapter 14 rather. Eileen L. Giovanna is the one who wrote this particular chapter, and it just outlines Lawrence Jones making an observation, refining it so he gets to a really good place for repetitive treatment to have a positive outcome, but the explanation ends up not necessarily holding up. So Lawrence Jones, an osteopathic family practitioner in Oregon, developed the counter-strain technique in 1955. He chanced on its discovery during the treatment of a patient with severe psoas spasm who had not responded to previous chiropractic or conventional osteopathic manipulation. After positioning the patient into a position of comfort, he left him on the table for a time, and when the man arose, he was pain-free. Dr. Jones spent many years perfecting the technique before introducing it. Now here's so that you get the stable observation. So he was able to get people pain-free by positioning them to comfort and leaving them for a period of time. What he then did was reduce the amount of time. So I think he started at 20 minutes, then he went to 19 minutes, down and down and down until he got to 90 seconds, because he noted that beyond 90 seconds, when positioning to comfort, you get no more relief beyond 90 seconds. So in this, it's page 86 of the book, the next thing that I'm going to read, the physiologic basis of counterstrain is based on the presumption that somatic dysfunction has a neuromuscular basis, right? So you have this presumption, they admit a presumption. So this becomes our general exemplar for how osteopathy has functioned. So my claim is that there is a stable observation. So you have a health problem and a mechanical dysfunction, not necessarily mechanical dysfunction with no health problem. So you have a health problem and a mechanical dysfunction observed at the same time. Osteopathic hands-on work is provided, and then the patients have a stable, generally positive range of outcomes. That is the consistent observation. But then you go to an explanatory step, and a lot of times you have a presumption. So what osteopathy has done is a lot of hypothesizing, and that seems to relate relatively well to the reality of the observed reality that osteopathy claims itself or describes itself as a philosophy more than anything else. So if you're working the philosophical realm, you can just do some thinking and explain things. That becomes a problem when your work is in the obligate physical world. When you're working on a patient, you have to be able to identify some change. That change, because it's a physical intervention, should be measured in physical ways. Because what you will identify if you look into the research realm is that a positive physical change does not necessarily equate to a positive subjective change. So the patient may think or may feel worse after a treatment that changes a physical phenomenon. The patient may feel better when that treatment has negatively impacted a physical phenomenon. So treatment and the physical change and the patient report don't always match up equally. They don't always go in the same direction. The patient report can be negative and the physical change can be positive. The patient report can be positive and the physical change can be negative. So they don't always relate. So we have a physical intervention, and osteopathy does seem to show a preference for asking the patient how they feel, as opposed to measuring how the patient has changed. Now, one of those changes is how the patient feels. That obviously has some merit, but there are other changes. So the changes in motion capacity, motion quality, changes in internal processes such as blood flow, such as neural conductance. These are all things that can be measured. So what I would suggest, again, is that osteopathy has done a lot of thinking and pontificating as to why things work, but it hasn't done it in a way that would relate well to what drives the common observation, the central phenomenon. So the central phenomenon is an obligate physical reality. The explanatory attempts have been in the realm of thinking, right? So the realm of practitioners thinking to try to explain. And we continue to come across this problem where we make these hypotheses, or really we just think and explain and don't treat it as an appropriate hypothesis, which is why we're missing the point. And then more thinking and more thinking and more thinking. So every time you have to accept the null hypothesis, you say, well, I have a new one, which is actually fine in the scientific method, but we're working from the realm of thought, the realm of philosophy, to talk about the realm of obligate physical reality. Methodologically, osteopathy is going to improve, or have the chance to improve, more readily if we go into the realm of obligate physical reality. We have a stable observation across time. Patients improve through osteopathic treatment in a relatively positive general range of results. So we've got that. But we keep dancing around in the philosophical realm instead of the positivist realm. So the way to figure this out is better predicted by being a positivist than it is by being a constructivist or being a philosopher. So osteopathy, while it's completely acceptable to claim it as a philosophy, if you want to figure out what the heck it's actually doing, you need to come into the realm of obligate physical reality. So again, lots of talking to provide support for my prediction that osteopathy has a lot of hypotheses and really no theory. So osteopathy is generally devoid of theory because nothing's been accepted, or you haven't been able to get to a point where you can accept your hypothesis or your prediction as to how things work. We know that we have a stable phenomenon. The way that we've been trying to explain that stable phenomenon has not necessarily been in line with how you should do it, or how you ideally would come to an appropriate explanation to generate a theory. So again, osteopathy would be well served to attempt to move into the realm of positivism, because that's actually the realm that osteopathy works in. Osteopathy works in physical reality. It does not work in the mind. Its intervention is in obligate physical reality. It is not in the mind. You can have people say that it's about how you think, and that's absolutely fine, because how you think will drive how you behave, but it is how you behave that is positive for the patient, right? So it is the osteopathic behavior in obligate physical reality that provides a net benefit to the patient. That may be driven by the thinking, fair enough. We can alter the thinking in a way that is more in line with obligate physical reality if we use those methods. So again, my central claim here, osteopathy is devoid of theory. It has a lot of hypotheses that are unacceptable, and it have proven so through testing. So if we switch how we're doing this, we may have a net benefit. So hopefully that was useful to you, and I will speak to you again.